This is a third case of a 67 years old man with a 3-vessel disease, diabetes mellitus, all the atherosclerotic risk factors, with a very tiny left anterior descending artery by 1 millimeter. The first procedure consisted of Lima to LAD anastomosis with a transit time flow measurement clearly demonstrating the occlusion of the artery, the malfunction of the graft. The colleague who performed the operation, this is very interesting, decided not to revise the anastomosis, thinking that probably the revision unlikely would result in a better outcome. This is on the other side. This is the transit time flow measurement of the second graft, saphenous vein from aorta to marginal artery, and it seems to work nicely. Actually, the first case, the first measurement was a true positive. The second was a false negative, because we took the angiography and the anastomosis, the LAD was, the LAD was completely occluded, and the Lima to LAD was occluded proximally, or the flow was back and forth, and the graft was distally occluded to the marginal artery. So the surgeon asked me to reconsider the patient for a redo operation. We did the case, and we found intraoperatively the complete thrombosis of the Lima to LAD. Look, this is the Lima. This is a transverse section. Look, it's full of thrombi. And but the Lima was still functioning up to 4 centimeters far from the anastomosis. So we decided to cut the Lima and reuse it for a new anastomosis proximally to the previous site. And what happened? We had a very nice flows through all the grafts. This is, we added a vein to the distal LAD, and the core flow mapping demonstrating the full function of all the anastomosis. And this was demonstrated by the angiography. This is the Lima to the proximal LAD. Very tiny vessels, as you can see, very tiny. Look, maybe by 1 millimeter. This is the vein to the distal LAD with a full refilling of the tiny LAD actually. But the flows in this case, if you look at the flows, the mean flow is very low, is on the lower side. This means that maybe a surgeon would have pushed to redo the anastomosis again. But we had the method to demonstrate that those anastomoses were fully functioning. So this is a case of test positive to the flow demonstrated to be false positive, because actually all the anastomoses were patent. Looking at the literature, there's a very interesting paper published in literature in 2000, this year in 2010, on Journal of Thoracic Cardiovascular Surgery, from the group of Steve Freems from Canada. They are, as you know, mainly oriented to the use of the so-called SPY system, the NOVADAC. So they study deeply this system, comparing sometimes to the transit time flow measurement. It's interesting to go deeply in this paper. This is a single-center, randomized, single-blinded controlled clinical trial with a patient randomized to either two groups: intraoperative graft patency assessment using either indocyanine green fluorescent angiography and transit time flow measurement, compared to the control group with no control at all. The conclusion are that the routine intraoperative graft assessment is safe, but does not lead to a marked reduction in graft occlusion 1 year after bypass grafting. That means that it doesn't mean anything, it's not useful at all, so you can do without it. But going deeply in the description of the study, there were 3 crossovers in the control arms, 3.4%, involving 8 grafts. Involving 8 grafts, which were assessed using experimental intervention, indocyanine green or transit time flow measurement on the basis of surgeon suspicion regarding graft anastomosis quality. None of these 8 grafts met the a priori criteria for graft revision, yet 5 grafts were revised as per surgeon decision. Conversely, in the imaging group, 8 of the total of 234 grafts constructed met criteria for revision. However, only 4, 1.7% grafts involving 4 different patients were revised. The unrevised 4 grafts that represented the protocol violations were attributed to the surgeon's judgment that revision was unwarranted and unlikely to result in a better outcome. I would add to this paper, any doubt would have been solved with EACTS. So it is not true that intraoperative graft verification doesn't mean anything. This is the proof that it's definitely mandatory and it's useful to assess the graft patency. But a second question that's very important is, does the surgeon have the attitude to use EACTS? This is another important question because, in my past, in my training period, I used to do vascular diagnosis by means of Doppler, continuous wave Doppler, and then the core flow mapping and 2D and so on. So I know what means imaging formation with the aid of the echography, but and this is why I was facilitating in this task. But what happens in case of a completely unexperienced surgeon who started to use this method? You should take into account that the implementation of EACTS, the morphology of the anastomosis, inside a TTFM equipment, the functional study of the graft, generates a new kind of diagnostic method, whose meaning is the integration of both of them, becomes a complete graft verification procedure. It's like to have the angiography inside the OR because the diagnostic accuracy reaches more or less that of the angiography. So we conducted a blinded observational study on surgeons' attitude from August 2009 to July 2010. All the surgeons were expert in transit time flow measurement verification, so were asked to implement a new tool in their clinical practice after having acquired basic principle of vascular diagnosis by echography. The planned protocol considered either longitudinal and transverse acquisition. All the surgeons ignored the aim of the study in progress. The number of surgeons involved were 6 unexperienced plus 1 experienced. The number of patients studied 237, among which 161 isolated CABG. The other mixture of different kind of procedures. I would stress that we carried on the procedure even in aortic valve replacement, in aortic dissection, in ventricular septal defect, and mitral regurg. This is the result of the study. We found that among 6 unexperienced surgeons, 3 of them showed the positive attitude to use the method, but 3 of them showed completely no attitude respect to the method. They refused to use, but it should be said that those 3 surgeons are the more reluctant to use transit time flow measurements, even if they use because they are obliged to use in my institution. So at least one method of intraoperative graft verification is used in our team. Not all the experienced surgeons show equal attitude with respect to echo-diagnosis. And among unexperienced surgeons with positive attitude, color flow mapping, and this is another additional information, is preferred to B mode. Some insights. The unexperienced operator seems to be more attracted by color flow mapping more than B mode scanning, even if the latter can provide more meaningful information about technical aspects. Based on this observational study, and based on the 100% of use of TTFM in our institute, it's reasonable that confidence with EACTS will increase with its use. So this is our protocol for the graft verification procedure using both methods. First of all, it should be done a cross-sectional B-mode scanning and then a longitudinal B-mode scanning, switching to the cross-sectional coral flow mapping and longitudinal coral flow mapping, and then afterward to use TTFM for measure the flow. But is EACTS a substitute of TTFM? The answer is not, obviously, for many reasons. TTFM provides a diagnostic accuracy if parameters values are far from cutoff published. It's very useful in giving functional information about distal runoff. This means that maybe they provide a very nice tool to predict the late failure or the late patency of the graft. And then, very important, to provide the principle for the functional analysis of a competitive flow of Y graft. What about EACTS? The coronary site selection, it's very important on the strategical point of view. It helps to reduce the false negatives, to reduce the undue revisions in those testing positive, in reducing reprocedural costs, and in increased intraoperative patency. The sum of this cooperation with two methods, the integration of these two methods, it is an increase of intraoperative diagnostic accuracy and more accurate late prediction. Thank you. Thank you very much.